simple thing to go from an evidence-based practice, an evidence-based intervention, and suddenly move it into practice and it works perfectly. That doesn't happen in any area of health behavior or health practices or medicine, and it's particularly an issue here. And so as Judy mentioned earlier today, it's not just a matter of, and then we scale it up. And a lot of the issues that we face in scaling things up are, of course, structural issues, but they're also social and behavioral issues. And so it'll be great to hear today from a series of speakers about issues that they work on, interventions that they work on, and the issues that they confront, the challenges they have confronted and are trying to deal with in moving things into scale. So our first speaker is Dr. Albert Liu, Al Liu. He is the Director of HIV Prevention Intervention Studies with Bridgman at San Francisco Department of Public Health. He's also Clinical Research Director, and he has an appointment with UCSF. And he's an example of why the San Francisco Department of Public Health is such an amazing place, because they do original research there and then move it into practice. So Al, thank you.
Thank you so much for that kind introduction, and I just wanted to thank Margarita and the organizers for inviting me to share some of our work that we're doing at the Health Department. So just as background, we know that young people, particularly young men who have sex with men, are among the most vulnerable in terms of HIV infection. And in particular, young MSM of color are disproportionately affected by HIV. And in terms of the PrEP cascade, the HIV testing is one of the first steps for both the treatment and the prevention continuum. And we know that it's suboptimal for youth. About only half of young MSM reported having an HIV test in the past year, and actually a third report that they've never actually ever had an HIV test. And while it's really exciting that we have pre-exposure prophylaxis as a new tool for prevention, and it's scaling up in a number of different populations, we also see disparities in youth, both in terms of uptake, as well as engagement and retention, as well as adherence. Based on some pharmacy data that was recently reported, only 11% of men initiating PrEP were under the age of 25. And so technology can be one strategy to try to support HIV testing, as well as PrEP uptake, adherence, and engagement in young MSM. And so today I'm going to give you 3 examples of some projects that we've been working on at the Health Department. The first is called PrEPmate. It's based on an SMS intervention to support retention and adherence to PrEP. And that study just completed. And then the other 2 are underway. In fact, the first one's just starting. And the second is called Links, and that's developing an app to increase testing and PrEP uptake. And finally, Diary, which is an app to help monitor adherence and as well as support adherence. So why technology for young folks? We know that smartphone ownership has nearly saturated, particularly among youth, and you can see here in the 18 to 24-year-old range that 98% of folks reported having a smartphone. And we see a pretty good balance of different operating systems, the most common ones being the Apple iOS, as well as Android platforms. And there's pretty similar uptake in terms of gender. And what we also know is that from studies that youth are actually more likely to use phones and apps and online information to seek information about health. And in particular, young African American individuals are more likely to both own a smartphone and also use some of these online technologies. So the first project I'm going to talk about is called PrEPmate, and this is a combination intervention that is based off of some work that Rich Lester has done in Africa. And in their studies, they were using a weekly SMS-based check-in, how's it going, for people living with HIV. And if they said that they weren't doing well, then they would get an outreach call from someone at the clinic. And they found that that simple intervention actually increased adherence and viral suppression in that study. And so what we wanted to do is see if we could adapt that approach for PrEP use in young people. And so we developed a system where people get a weekly check-in, and it's either, how is PrEP going or how are things going? And if people say that they're, not doing well, then we'll reach out to them. And what we found was that some of the youth really don't like talking on the phone. They just all prefer texting. And so they, sometimes it would initiate these series of texts back and forth with the clinic. And sometimes, they would say, well, why don't you come into the clinic and get some additional support. They also felt that they wanted some additional types of engagement. And so we built in some video testimonials from some youth talking about their experiences taking PrEP, how they decided whether to take it or not, and if they experienced any side effects, how to deal with them, and also created a forum behind sort of a password-protected site that people could talk with other PrEP users as part of the study. So after developing this intervention, we actually went ahead and tested it within the Chicago safety net system, which at the time was just starting up and really trying to expand their PrEP services. So we enrolled youth, young MSM, between the ages of 18 to 29 into the study, and they were provided 9 months of free PrEP, and that it was at a time where they were still, they're still figuring out some coverage issues, so we didn't want medication access to be an issue. However, the visits themselves were part of just the usual standard of care, and so their visits and labs were covered by their insurance or in some cases even paid out of pocket. And participants in the study were randomized 2-to-1 to receive the PrEP-mate intervention versus the standard of care, which included risk assessment, PrEP education, and some brief adherence counseling conducted by a health educator. This just shows the baseline characteristics of those who enrolled in the study. You can see that the mean age was about 24, about over a quarter were African American, and over a third were Latino. Most people had some college education or higher, but over half had an income less than $20,000. And if you look down, you can see that, they were quite a sexually active group. The mean number of anal sex partners was 7. About half reported condomless receptive anal sex within the past 3 months, and about a quarter reported an STI. So this slide shows the overall patterns of retention and PrEP adherence in the study, and this is the overall cohort, so both arms combined. And what the categories are based off of drug levels in dried blood spots, which give you an average of how many pills per week that they were taking. And so you can see that the most optimal is in the light blue, where they were taking 4 or more doses per week, which has been shown to be highly protective for rectal exposures. And then it goes down to BLQ, which is below the limit of quantitation, meaning that we didn't detect any drug in their system. And then the lowest bar in red is actually that they didn't come in for that particular visit. And you can see that overall, initially at week 4, we saw high levels of engagement, both few missed visits and high adherence, but it did drop off over time. And by week 36, the last visit in the study, only half of the original cohort had maintained protective levels, and a quarter actually missed that visit. So now this is data showing broken out by the intervention groups. And so in the green is the PrEP-mate arm, and in red is the standard of care arm. And this is looking at visit retention by the visits. And you can see that across the visits that there was greater retention in the group that received the PrEP-mate intervention. 86% of visits were retained in the PrEP-mate arm compared to 71% in the standard of care arm, for an overall odds ratio of 2.6. We did adjust for factors such as depression, which were a little bit imbalanced at baseline, and that did not change the result. So then this is looking at, so that outcome was retention. Now this is looking at adherence. And the way we defined that was that they came to the visit and they had a drug level that was above 4 or more doses per week. And same setup with PrEP-mate in green and standard of care in red. And again, you can see higher adherence, 72% of visits with protective levels compared to 57% in the standard of care arm, with an overall odds ratio of 2.0. We did look at whether this effect differed by different subgroups, including age, race, ethnicity, education, or insurance, and did not see differences in efficacy. We also wanted to ask about acceptability of the app or the SMS intervention. So these were a couple of the measures that we asked about in the intervention arm. And the majority of individuals felt that the PrEP-mate was somewhat or very helpful. They wanted to continue to use it after the study, and they would recommend it to other people. In terms of negative aspects, there were very few people who were worried that other people would see the texts, and very few people who had problems sending or receiving text messages. And we did monitor for social harms, and there were not any reported in the study. We did want to get a sense from people on, what their experience was like receiving the text messages, and did they help in any other way. And one participant said the sense of having a somewhat total stranger watching out for another person was great to have. Jen, who is the study coordinator at the Chicago site, was that total stranger to me. And her and I have developed a pseudo-friendship through PrEP-mate. Her weekly check-ins gave me a sense of community camaraderie that can sometimes be lost in this day and age. So the second project I wanted to share is called Links, and this is a study that we're just launching through the new Adolescent Trials Network. I'm working on this project with my colleague, Dr. Hyman Scott. And the goal of this app is to encourage youth to engage in HIV testing and PrEP uptake. But what we heard early on that they didn't want just an app focused on that. They wanted sort of a broader app focused on sexual health and more interactive, have some gamification features in it as well. So that's been our approach to developing it. Two of the key components of the app are shown here. The first is this thing called Sex Pro. And what we learned in some of our early formative work was that many of the youth felt that they didn't know all the things that, whether they were at risk for HIV and even some of the behaviors that might contribute to that. So we built in this sort of sexual health score that people answer a few questions. They get a score from 1 to 20, where 20 in the green is more protection from HIV. And so this is something that people can do initially and follow over time as well. The other component is a sexual diary that people can enter in their sexual encounters. They can rate their partners and how great the sex was. And that information will also be fed back to people so they can track how they're doing. In terms of encouraging HIV testing, we wanted to facilitate testing in any way that they wanted. And so there's ways to order home test kits that can be mailed out to either their home or a clinic that they're affiliated with. Also, there's a geolocator-defined HIV and PrEP delivery sites in their community that also have experience working with youth. And this is just showing one of the gamification features that they can earn different badges as part of using the app. And this is just showing how we're trying to develop this in a rigorous, methodical way. We're doing some initial formative work. We're going to do a technical pilot and then move into a pilot RCT. So the last project I'm going to talk about is called Dot Diary. What we know from PrEP is that adherence is really critical for it to be effective, but we don't have a great way of measuring adherence. And some of our traditional ways, such as pill counts and self-report, have had limitations. And so NIH actually put out an RFA to develop new technologies to measure adherence in different ways. And some of the qualities of an ideal measure would be that, it confirms that people actually ingested an oral agent, that it can track longitudinal patterns over time. It provides some real-time adherence monitoring and gives people feedback. And so that's the goal of the Dot Diary project, is actually building on this concept of automated, directly observed dosing. And we wanted to integrate that with a sexual diary to see if it could help meet some of these characteristics. And so we're partnering with a company based in New York called AI Cure, and they have developed a platform that uses artificial intelligence and motion sensing technology in people's smartphones to actually do, DOT, directly observed dosing. So they, show the pill and then they, swallow it, and you can set it to different levels depending on how much, what can be incorporated into people's lives. And the way we're trying to customize this for PrEP use is that they're entering all this data in, and we wanted to be able to give people back information about their dosing. And so what we're going to do is be able to show people their protection level based on doses per week that they're taking. And so you can see here is an example of high levels of protection because this person dosed 5 days in a row, versus a person who's missed 2 doses and has medium levels of protection, and then someone who's missed multiple levels has low protection, and they would have sort of individual personalized messages like, okay, you could take 4 more doses or 3 more doses to get back up to high levels of protection. And this just shows that we wanted to be able to overlay people's dosing information with their sexual diary data so that people could see what are their patterns of pill use in relation to the sex that they're having. So just to conclude, we know that HIV testing rates and PrEP uptake and adherence has been low among youth, and mobile technologies are one potential way to reach out to this population. We have evidence now that an SMS-based approach can be useful in supporting PrEP adherence and retention in youth, and we're currently testing some new apps to support outreach and support for youth. So that's what I wanted to cover today, and happy to take questions at the end.
And thank you, Margarita and all, for inviting me here. So in the next 15 minutes or so, I'm going to give a very brief overview of why food insecurity is bad for your health in HIV. I'm also going to broaden to the context of chronic diseases, which are very relevant for many of the HIV programs that are being implemented worldwide. And then I'll focus most of the time on food security interventions and how they can reverse the vicious cycle of food insecurity and poor health. So food security is defined as access by all people at all times to enough food for an active, healthy life. And conversely, food insecurity is the limited or uncertain availability of nutritionally adequate, safe foods, or the inability to acquire what's thought to be personally acceptable foods in socially acceptable ways. Hunger and food insecurity are very large and persistent problems in this country. So it's estimated that 13% of all U.S. households are food insecure. And as you can see, food insecurity disproportionately impacts minority as well as low-income households. Food insecurity is even more prevalent among people living with HIV. And you can see that studies from across US and Canada show that about half of HIV-infected individuals in care are food insecure. Worldwide, HIV and food insecurity can be thought of as syndemic issues, And you can see that the regions of the world that have the highest prevalence of food insecurity, shown in the top maps in the pink and red colors, strongly overlap with those regions with the highest HIV/AIDS prevalence, shown in the bottom maps in the purple colors. So here's a conceptual framework we developed to understand the vicious cycle between food insecurity and poor health. Food insecurity first directly contributes to poor nutrition, poor mental health, and poor adherence to treatment and care recommendations, which in turn can drive both HIV acquisition risk as well as worse outcomes both in HIV as well as in chronic disease. This then drives utilization of expensive healthcare services like hospitalizations and ED visits, which then drive up healthcare costs. And then as a result of increasing disability and out-of-pocket health expenses, this then further entrenches individuals into poverty, unemployment, and food insecurity, perpetuating a vicious cycle. So just starting with the first steps in the model, lots of studies show that food insecurity contributes to micronutrient and macronutrient deficiencies and is also a growing contributor to the obesity epidemic in this country and elsewhere. For example, in a study in the Women's Interagency HIV study, and in this analysis led by Nicole Saratin, we found that food insecure, HIV-infected, and at-risk women had twice the odds of being obese compared to women who were food secure. Food insecurity is a very important determinant of poor mental health and contributes to depression, anxiety, drug and alcohol abuse disorders, and other mental illnesses. For example, in an analysis led by Kartika Pilar in San Francisco, we found that food insecure individuals had 60% higher odds of screening positive for depression, and we also saw similar things in our longitudinal work in Uganda. Food insecurity also drives poor health behaviors like medication non-adherence, treatment interruptions, and missed clinic visits. As an example, in a national study among over 65,000 adults in the general population in the US, severely food insecure individuals had 3.7 times the odds of skipping their medication doses and 4 times the odds of delaying their medication refills. So food insecurity can negatively impact individuals along the entire cascade of care for HIV. Food insecure individuals have 3 times the odds of being HIV infected, 2 times the odds of missing clinic visits, 2.7 times the odds of ART non-adherence, 70% higher odds of failing HIV therapy, 45% higher odds of progression to AIDS, and are even 2 times more likely to die compared to individuals who are food secure. So if we want to meet our 90-90-90, 10-10-10, getting to 0, whatever targets you want to go for in the setting, we do need to address food insecurity. And I will just point out that outside of the context of HIV, food insecurity is linked with a host of chronic diseases. So population-based studies from the US show that food insecure individuals have twice the odds of developing diabetes and also have higher odds of hypertension, high cholesterol, osteoporosis, chronic kidney disease, and many other issues. Importantly, food insecurity does drive utilization of expensive healthcare services. For example, in San Francisco, we saw that food insecure individuals had twice, or severely food insecure individuals had twice the odds of being hospitalized and 71% higher odds of ER visits, which really does suggest that not addressing food insecurity ends up being costly for the healthcare system over the long run. So then how do we begin to address this vicious cycle of food insecurity and poor health? Well, there are many possible interventions in place, ranging from targeted food supplementation in clinics and food banks, to food stamps and voucher programs, to more upstream interventions like cash transfers for food, which we'll hear about shortly, some of Sandra McCoy's exciting work in this area, as well as livelihood and vocational training programs. And I'll just give a few examples in both domestic and international, in the international context. So the bulk of the evidence does support that food security interventions can reverse the vicious cycle of food insecurity and poor health, can contribute to improved HIV and chronic disease health, and may even decrease acute care use and health costs. So starting with targeted food supplementation, a number of studies show that food support does indeed improve nutritional status. For example, we conducted, along with Kartika Pilar, a study at Project Open Hand, where we provided comprehensive nutrition to individuals with HIV and/or diabetes. And we saw in recipients of the meals a 52% reduction in food insecurity, statistically significant decreases in fat and sugar consumption, and statistically significant increases in fruit, vegetable, and dairy consumption. Studies also show that these programs can improve mental health. For example, in our Project Open Hand study, we saw a 23% reduction in both symptoms of depression and distress related to their chronic illness, and other studies have found similar things. Finally, food support programs can improve health behaviors, and this is shown in both studies with individuals living with diabetes and HIV. For example, in our Project Open Hand study, only 47% had excellent adherence at the beginning of the study, and that increased to 70% at the end of the study. And another study in New York City found that recipients of medically tailored meals, and these are HIV-infected patients, had 68% lower odds of missing their appointments. So in the international context, and focusing specifically on ART adherence, a number of studies, including Sandy's, which she'll talk about, show that food support can improve ART adherence and retention in care. And at least pilot studies thus far are suggestive that food support may reduce hospitalizations and ER visits, and some larger studies are underway. And I just want to point out that food support is actually, when you consider the alternative, a relatively inexpensive intervention. So it's estimated that you could feed someone for half a year for the same price as one day in the hospital, and that includes food costs as well as personnel costs. And exciting news is that Governor Brown just approved a statewide demonstration project with Project Open Hand and a number of other food support organizations to provide food support to chronically ill individuals. So in the last few minutes, I'm just going to turn to some longer range approaches, like livelihood approaches, that may be harder to implement in the short term, but more sustainable over the long term. And these approaches really do require us to have transdisciplinary partnerships, including the health sector and other sectors like agriculture, finance, and policy partners. So we tested one such approach with Craig Cohen and Elizabeth Bakusi in Kenya, who are my co-PIs. The study was entitled Shamba Maisha, which means farm life in Kiswahili. And the goal was to target the root causes of poverty and food insecurity, which in this context was inconsistent rainfall and frequent drought, increasing in the setting of climate change. We tested this in 2 clusters of 140 people. The intervention had 3 components: a microfinance loan to purchase a human-powered water pump and other farming implements, and education in sustainable farming practices and financial management. So in our framework, we had hypothesized that this multi-sectoral agricultural intervention would first improve food security and wealth, and then through the various pathways I've already gone over, as well as a new pathway of enhanced empowerment, would lead to decreased HIV morbidity and mortality. And I will briefly show you our findings. You'll note that the intervention group is shown in the blue circles and the control group in the red X's. You can see at baseline very high and similar levels of food insecurity in both groups. And by 6 months, we already saw statistically significant reductions in food insecurity in the intervention compared to the control group that persisted throughout the rest of the trial. While we were not powered to look at HIV clinical outcomes, we did in fact see statistically significant improvements in the proportion virologically suppressed. And this was, to our knowledge, the first trial to link an agriculture or livelihood intervention to hard clinical endpoints. Similarly, we saw statistically significant improvements in CD4 cell count. And as a measure of empowerment, we saw some statistically significant improvements in self-confidence. Our qualitative data supported the nutritional, mental health, and behavioral pathways through which food support through which the Shamba Misha intervention improved health. And I'll just read you one quote in the mental health pathway. "It has given me hope and will to do my things, not like before when I used to be hopeless and scared. I also have the will to go about my duties and farm, from which I get food and money, thus living like any other person." And I just want to point out that the intervention impacted things beyond HIV clinical outcomes. So Lisa Butler had a paired R21 study to look at pediatric growth and development outcomes and saw statistically significant improvements in height and weight for Z-scores. Our qualitative data attested to reduction in violence, as you can see the quote here, as well as reductions in HIV stigma. And we're now in the process of scaling up this intervention. We have a 16-site randomized controlled trial. We're in our third year. Lisa Butler has a paired R01 looking at pediatric outcomes. And with a number of you here, we just submitted another grant to look at adolescent sexual and reproductive health outcomes. And in the last minute or so, I'll just mention another strategy that is gaining traction in the US and elsewhere, which is urban gardening. There are programs cropping up in many locations, but very little data assessing its effectiveness. So we started with a small pilot study interviewing individuals living with HIV or at risk for diabetes or living with diabetes in San Jose, who were participants of the Valle Verde urban gardening program. And our pilot data showed that the intervention improved diet, exercise, reduced stress, improved mental health, and helped with weight control and management of chronic diseases. And similar to the Shamba Misha study, the intervention did show improvements in health along the nutritional, mental health, and behavioral pathways. And I'll just read one quote along the nutritional pathway. "My family has lost weight. We're cooking new things, losing weight, feeling healthier. We got blood pressures down. My oldest daughter was at risk for childhood diabetes. That's gone." So in summary, we've seen that food insecurity worsens HIV outcomes along the entire cascade of care and really needs to be part of our programmatic efforts to eliminate HIV. We've seen that food insecurity interventions can reverse the cycle and improve health. I hope I've shown you that improving food insecurity can, can address multiple health problems simultaneously, both within HIV and outside of HIV. And just to end with a plug that I feel particularly passionate about, given that climate change is a very important driver of food insecurity and poor health, that when we think about development approaches and food security approaches, we really should be thinking about environmentally sustainable approaches. And I'll just leave my acknowledgement slide up. Thank you very much.
Thank you, Sheri. Our next speaker will be Sandy McCoy, who is an associate professor of epidemiology at our sister institution across the bay at UC Berkeley. And she will be speaking about, while you're doing this, scaling economic programming and interventions.
Thank you. Thank you very much. Good afternoon, everyone. I'd like to thank the conference organizers for inviting me to speak, and I'm delighted to follow Sheri because this builds really well on her presentation. So I'll be speaking today about economic approaches to strengthening the HIV prevention and care cascade. So what I'm hoping to do in the next 15 minutes is to present a very high-level overview of the types of economic approaches that we use to strengthen the HIV prevention and care continuum. I'll discuss a few hypotheses for how these interventions might achieve their intended effects. And I'll also present some of the gaps in the evidence base that were revealed in a recent systematic review of household economic strengthening interventions. So as you know, economic status has long been recognized as an important structural driver of the HIV epidemic. For example, in sub-Saharan Africa, the HIV epidemic coincides with very high rates of poverty, which can fuel epidemic spread, either because it increases the likelihood that people will engage in higher risk behaviors, or because it will impede their access to the receipt of life-saving treatment and care services. So indeed, the World Bank estimates that 41% of the population of sub-Saharan Africa lives below the international extreme poverty line of $1.90 per day. Households often become poor after experiencing some kind of a shock, like a household member becoming ill with HIV infection. They then must engage in various strategies for survival. So minor coping strategies might include things like selling non-essential assets, looking for additional work, and reducing spending. As a family's economic condition worsens, households may have to continue to sell productive assets and reduce spending, but they may also begin to acquire high-risk or high-interest loans. In the most extreme situations, households can descend into extreme stress, and they'll have to rely on strategies like charity and begging to survive. They may have to break up their household or migrate for work, and in the worst case situations, as Sheri's just described, they might have to go without food. So the effect of extreme poverty seems to be the most acute around the time of HIV treatment initiation. These are data from South Africa that show the likelihood of employment before and after ART start. So you can see that there's this sharp decline in employment in the year before patients start treatment, followed by a slow but nearly complete recovery back to the labor force. So indeed, 4 years after ART initiation, employment in this study had recovered to about 90% of the baseline rates that were observed about 3 to 5 years before ART start. So these data provide rationale for economic livelihood strategies that help to build household resilience in the face of shocks, and especially those strategies that could be implemented around the time of treatment initiation. So this is the Lift to Livelihood and Food Security conceptual framework, and I think this is a really nice way to consider different categories of livelihood strategies that are best suited to varying levels of household vulnerability. For example, provision-type interventions like cash transfers, savings, and food and labor schemes are probably the most appropriate for the most vulnerable households, with vulnerability shown over here on the left-hand side of this graph. So those are the houses that are the most vulnerable. They might involve the people who are the sickest and who need the most support. And they also have very high levels of food insecurity. In contrast, the framework proposes that the protection and promotion interventions are better suited for households that are less vulnerable but still need some level of economic support. So these strategies focus on asset protection and consumption smoothing and might include things like group savings and loans, microinsurance, or livelihood activities. So how might household economic strengthening interventions achieve their intended impact, and what is some of the evidence for their effectiveness? So there's a strong theoretical basis for how economic interventions might strengthen the HIV prevention and care cascade. So based on classical economic theory, livelihood support, cash transfers, and asset transfers could help to overcome economic constraints either through an income effect, a price effect, or both. These types of support might provide an income boost that's often coupled through the use of a condition with an incentive to invest in a desired behavior or goal, like HIV testing. Education, training, and employment support may increase participation in the labor market and boost a household's likelihood of having some kind of income boost. Microcredit and other financial inclusion programs, like savings programs, relax access to credit markets, and they can increase access to other affordable financial products and services. And as Sebastian talked about this morning, there's a strong body of behavioral economic theory that suggests that things like cash and in-kind incentives can also motivate behavior change by counteracting the systematic biases or shortcuts that we use to make decisions. And these tools don't necessarily have to only be used in resource-constrained settings. They could, of course, be used everywhere to motivate beneficial or engagement in beneficial health behaviors. So I wanted to just review a couple of recent studies that have used an economic type intervention for the HIV prevention and care cascade. And Sheri's already done a really nice job of presenting some on the livelihood strategies and on food support. So I wanted to highlight a few recent studies that have used conditional or unconditional cash transfers or in-kind support. So this is the HPTN 068 study that many of you might already be familiar with, led by Audrey Pettifor and her team. This was a randomized study that was conducted in rural South Africa with 2,500 girls who were aged 13 to 20 years old. And the goal was to evaluate the effectiveness of a conditional cash transfer scheme on HIV incidence. So girls were randomized to receive either a monthly cash transfer conditional on school attendance or no cash transfer. and they followed the girls for 36 months and looked at HIV incidence. They found that there was no difference after 36 months between the two arms with HIV incidence. Now, this, of course, contrasts with other studies that have found an effect of cash transfers on HIV prevention, including the RESPECT trial in Tanzania and the Zumba cash transfer trial in Malawi. Moving on to the HIV testing realm, here's a study that focused on incentives for couples HIV testing and counseling in Zimbabwe. This was conducted by Euphemia Simbanda at SESHAR Zimbabwe, and she conducted a cluster randomized study of 68 communities in 4 different districts who were all receiving mobile HIV testing services. They found a 7-fold increase in the number of couples testing together with a very small in-kind incentive of either soap, petroleum jelly, or oil. And their incentive-based strategy nearly doubled the number of people living with HIV infection who were identified. So this $1.50 valued incentive resulted in 2.2 additional people living with HIV infection identified per day, and they did not identify any adverse events associated with this strategy. Moving into the treatment and care realm, this is a study that our team conducted in Tanzania. We evaluated the effect of short-term food or cash transfers for ART adherence and retention and care. So we randomized 805 food-insecure ART initiates to a short-term cash transfer, a short-term food basket, or the standard of care, which was nutrition assessment and counseling, or NAC. People could receive up to 6 consecutive months of support, and it was conditional on attending their clinic visits. And you can see our Kaplan-Meier curve over here on the right-hand side. The comparison group is shown in red. You can see that we had a pretty dramatic loss to follow-up out of care for our comparison group, but both the food transfer group and the cash transfer group were much more likely to remain in care, even after the intervention had ended. So at 12 months, we had lost 17% out of care in the comparison group, 6% in the cash group, and 10% in the food group. And here are our intent to treat results on adherence. We measured adherence with a measure called the medication possession ratio, which is the proportion of days that people have 1 dose of ART or more on hand. And we looked at MPR at an adherence threshold of 95%. So these first 4 columns here show you the percentage of patients who achieved MPR 95%. And these 3 columns here show you the between group differences. So these are like a risk difference. So at 6 months, if we compare directly the cash group to the comparison group, you can see that there was a 21.6 percentage point increase among the patients who achieved MPR 95% compared to the comparison group. The participants who received the food transfer also were statistically more likely to have achieved MPR 95%. And at 6 months, when we directly compare the 2 interventions, we find that they're statistically similar. So they're both beneficial at 6 months. When we look at the 12-month data, we can see that the effective cash transfers stay very strong. And remember that the intervention here is only 6 months, so this is 6 months after the intervention has ended. So people who were in the cash group were 19.5 percentage points 19.5 percentage points more in the MPR 95 group compared to those who were in the standard of care group. The food group is attenuated at 12 months, and when we directly compare cash to food, we see that the cash group does slightly better at 12 months compared to the food group. So how did these incentives work? So we find that they're both good strategies at different times. So in-depth interviews reveal that the incentives acted through 3 primary pathways to increase adherence. They addressed competing needs and offset opportunity costs. They increased motivation via a price effect. And they alleviated stress and anxiety, which is a mental health pathway that's supported by conceptual models and empirical data, including some of Sheri's data. So now let's take a look at some of the evidence gaps in economic interventions for HIV prevention and care. So although the evidence linking household economic strengthening interventions and a variety of HIV outcomes has been growing, until now there had never been a systematic way to put all of these studies together. So recently, the USAID-funded Aspires project at FHI 360 conducted a very broad literature review of the gray and published literature on a broad set of household economic strengthening interventions and their effect on a range of HIV-related outcomes. And Mandy Swan, who conducted the review, agreed for me to present a preview of her results to you today, as long as I mentioned that they would be published next year in a special issue in AIDS Care and also in December at ICASA. So I would encourage you to keep an eye out for that if you're interested. So here's a little bit about her methodology and her findings. So she identified 15 different types of household economic strengthening interventions, shown on the left-hand side of this slide, and she classified them according to the livelihood framework that I presented at the beginning of this presentation. And she also identified 10 different HIV-related outcomes across the HIV prevention, care, and treatment continuum, shown on the right-hand side of this slide. So after a comprehensive literature review, they identified 108 studies to include in their review that covered a range of research methods and contexts. And they created this lovely evidence map, shown on the right-hand side of this slide. And I recognize you can't see the details, but more I wanted you to see what a great visual resource this will be for all of us once it's published. So the left-hand side shows you all of the different household economic strengthening interventions, and across the top are all of the HIV-related outcomes, ranging from prevention to treatment and care. And they've indicated when there's a study in a particular exposure outcome combination with a dot, the positive studies are indicated in green. They also examined the quality of the study and whether the study evaluated independent or combined effects of the economic strengthening strategy. And just for an example, this upper left quadrant here shows you studies that evaluated the effectiveness of conditional and unconditional cash transfers for HIV prevention. And so you can see that just visually, there's just quite a bit of evidence in this quadrant already. But if you look in other areas of the map, like let's say in the beginning, you can see that, or in the middle, you can see that there's quite a thin body of evidence for many of these interventions. And many of the cells just have 1 or 2 dots, if any at all. So we have a lot of work to do in terms of understanding how these economic strengthening interventions might work for a vast range of HIV-related outcomes. So here were some of their findings based on their review. So they found that 67% of those 108 studies featured provision interventions. So these are the types of interventions that focus on asset recovery and consumption support, like cash transfers, savings, and food and labor schemes. They find that there's robust and positive evidence for cash transfers, educational support, and financial incentives on HIV prevention risk behaviors. But they note that only 13 studies that looked at HIV prevention measured a biomarker of HIV incidence. They also found strong evidence for financial incentives in HIV testing, as well as for food assistance and ART adherence. And they note that there's a growing body of evidence for cash and food incentives for retention and care as well. They note that there's far less conclusive evidence for the protection and promotion interventions that include vocational and entrepreneurial training and microcredit. And they note that there's weak and conflicting evidence for income-generating activities and savings. They also note that there's very little data to understand the influence of context. So in what settings do these type of interventions work best? How large or how intensive do these programs need to be? So these are some of the main questions we need to tackle next. And I'd like to just end with some recommendations for future studies for those of you in this room working in this area. So economic approaches are often implemented as part of an integrated package, but the contributions of those individual components are often unknown, and that's an area for us to try to do better. We need greater rigor in our measurement. This includes using biomarker data when possible in prevention studies, better measurement of self-reported behaviors, and greater standardization of indicators across studies so that we can facilitate comparisons. We need longer studies to understand effect durability and whether these programs can be sustained. And lastly, we need better documentation of the programs or interventions themselves, again, to facilitate comparisons and synthesis across studies. So with that, I would just like to thank all my collaborators on the Tanzania study, as well as Mandy Swan for sharing the preview of her review, and also to those who I talked to about the presentation today and funding from NIMH. Thank you.
Thank you, Sandy. All right, our next speaker is Dr. Eddie Machtinger. He is a professor of medicine here at UCSF, and he's the director of Women's HIV, of the Women's HIV program, and has been doing lots of work for many years on the relationship between violence and HIV among women. So thank you, Eddie.
So hello, I'd like to thank also Margarita and Susan for inviting me to present today and for elevating the issue of trauma in our shared effort to end AIDS. It's really an honor to be here with such an esteemed group of my friends and colleagues who are doing totally amazing work, and with all of you. So in the next 15 minutes, my plan is to discuss the impact of trauma on the health and well-being of people living with HIV, and to describe a practical model of trauma-informed primary care that can interrupt this impact by facilitating healing from past abuse, preventing re-victimization, and informing healthier coping strategies. I'll end by tying this all together by identifying trauma-informed primary care as a key element of successful HIV treatment and prevention. I'd first like to acknowledge our UCSF team and community partners. We're doing a prospective mixed methods study of trauma-informed primary care for women living with HIV. I see a number of my colleagues in the room today. Carol Dawson-Rose is here. She leads our research effort and has been an amazing friend and mentor to me. Yvette Kuka is here, and she leads a number of our sub-studies, so thank you so much. So the Women's HIV program, WHP, where I work, was among the first HIV programs specifically designed for women living with HIV in the country. And because we have funding from Ryan White, in part, we are able to provide on-site interdisciplinary care, including primary medical care, gynecology and obstetrics, social work and case management, therapy and psychiatry, linkages to substance abuse treatment, and a communal breakfast before each clinic with patients and staff. Most of our patients are women of color, inclusive of transgender women. They're mostly low income, and most of them are facing an array of psychosocial and health challenges. So before the next slide, let me just pause and say, to share a realization I had about our supposedly amazing clinic. So in our clinic, over 85% of the women are prescribed antiretrovirals. Of those, over 80% have undetectable viral loads, which are both far higher than national averages and even a bit higher than the averages in Ryan White primary care programs. And because of this, our program consistently gets really good monitoring scores from our federal funders, and it's considered a national model of care for this population. But if you scratch a little bit beneath the surface, you realize that 40% of our patients are using hard drugs like methamphetamine, cocaine, and heroin. 50% of our patients are clinically depressed. Very few of our patients are completely out about their HIV status, meaning they don't have the ability to form real friends and social support networks to help them through a lot of their challenges. Many of them are living with abusive partners. Almost none of them are working, despite clearly wanting to work, and way too many of them are dying from preventable illnesses. So the disconnect I mentioned is evident if you look at how people die in our clinic. So after someone dies in our clinic, we have a case conference to try to understand what happened, to mourn her loss, and to try to learn from it. And here's just a sample of the recent deaths in our clinic at the Women's HIV program. Murder, murder, suicide, 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 addiction, 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 pancreatic cancer, and Pebbles, who I met at 15 years old, who died at 22 years old after losing her mom to crack addiction and AIDS. She was in the foster system, she was in the criminal justice system, and a year after she delivered her first baby, she stopped her medications due to hopelessness and depression and died from a completely preventable brain infection, PML. And these women were all really different, but they share a common history of experiencing lifetime trauma, which led to their HIV infections in the first place, and then led to their deaths directly in those who were murdered, and indirectly through substance use, overdose, depression, suicide, isolation, and hopelessness in the others. And we concluded that our clinic, and really our primary care system, is not resourced to deal with the danger that many of these women face. And I think even more importantly, is not resourced and does not have the services designed to help our patients heal from the serial abuse that most of them have experienced and gain the self-efficacy and social support to overcome addiction and leave abusive partners. So we committed then to perform the research and advocacy necessary to change our program to one that really tries to meet this need for patients. So a few definitions, and this if probably less necessary for this crowd. SAMHSA defines trauma as an event, series of events, or set of circumstances, such as physical, emotional, or sexual abuse as a child or as an adult, neglect, loss, community violence, or structural violence, including racism, sexism, transphobia, homophobia, xenophobia, HIV-related stigma, and other causes of toxic stress that are experienced by an individual as physically or emotionally harmful or threatening, and that have lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. It's kind of a trauma with a capital T. A few more important definitions. Complex trauma is repeated trauma, physically or emotionally. This is what most of the people living with HIV who we take care of experience, and this is repeated childhood physical abuse or neglect, or witnessing your mom in an IPV situation throughout your childhood. Post-traumatic stress disorder can be a result, a consequence of this trauma. It includes 4 types of symptoms: re-experiencing of the traumatic event, avoidance of situations that remind you of the event, negative changes in the way you think about yourself, other people, or the world, and feeling keyed up. And complex PTSD is a reaction to complex trauma and includes all the symptoms of PTSD, as well as trouble regulating and handling emotions and relationships, and feelings of low self-worth and powerlessness. And complex PTSD, when I first understood that, was a revelation to me. It helped explain why our waiting room was so chaotic. It helped explain why people were so reactive or were standing in the waiting room really trying to disappear. It explained why so many of my patients were using substances and were refractory to so many different interventions. It was really helpful to understand that they didn't have personality disorders, that they had, and they weren't, it wasn't mysterious why they were acting the way they were acting. It was because they had complex PTSD. So we wanted to look, we want to understand whether the rates of trauma that we were seeing in our clinic were representative of the national reality for people living with HIV. So we did a meta-analysis of the 5,930 individuals, women, inclusive of transgender women, living with HIV, and the studies done of them. And we found, and I'm just going to highlight 3 findings, 55% of women living with HIV have experienced intimate partner violence, which is almost twice the national rate. 61% of women living with HIV have experienced lifetime sexual abuse. 30% of women living with HIV have current PTSD, which is 6 times the national rate. We then looked, we did a cross-sectional study to determine factors associated with virologic failure in our population. We looked at 113 patients, mostly women of color, 30% transgender women, and we found that recent trauma had 4.3 times the odds of people who had experienced recent trauma had 4.3 times the odds of experiencing medication failure compared to those who did not. And it's not that the other factors on this chart were not associated with non-adherence and medication failure in general in other studies. It's just that the study wasn't powered to determine that. What was so remarkable to us about this study was the strength of the correlation between recent trauma and virologic failure. I'd like to illustrate the impacts of recent and past trauma on the care continuum. This is an older version of the care continuum, not updated to 2014 and not updated to the Ryan White care continuum, both of which have better outcomes. So people have experienced intimate partner violence or recent trauma have 1.3 times the likelihood of needing to wait 90 days to be engaged in care. They have twice the rate of being lost to follow. They're half as likely to be prescribed ART when it's medically indicated. They're 2 to 3 times more likely to be non-adherent to antiretroviral therapy, and they have between 1.3 and 4 times the rate of medication failure. Similarly, for lifetime trauma, people with lifetime trauma have almost 2 times the odds of not being on antiretrovirals when medically indicated, and there's a significant association with lifetime trauma and medication non-adherence, and it's in a dose-response fashion. The more lifetime trauma and childhood trauma you experienced, the less rate of adherence you're able to achieve. And these studies, 50% of the studies in the last 2 slides included both men and women. So there are other non-biological social and behavioral determinants to poor outcomes at each stage of the care continuum. And it's important to note that both childhood and adult trauma and PTSD have been shown in multiple studies to be strongly correlated with many of these conditions. And this is particularly true of the conditions listed on the left, left side of that box. So it's important to recognize the contribution of trauma and PTSD to these conditions because effective treatments for them require concurrently addressing trauma and PTSD. And the data for this is especially strong in substance use and depression. I also think it's really important to look at how people living with HIV are actually dying. So increasingly, people living with HIV who die don't die from AIDS, but from preventable causes of death that are highly correlated with trauma. So in our clinic, we performed a case series of deaths that included chart review and interviews with providers and found that only 16% of deaths of those patients in our clinic died from AIDS. And there's a similar trend in the Women's Interagency HIV study, which shows since 2004, less than 40% of deaths were due to AIDS. And now, 10 years later, it's way lower than that. Most people living with HIV, especially women, are dying from substance abuse, overdose, depression, suicide, and a variety of medical illnesses like obesity, diabetes, heart disease, lung disease, liver disease, many of which are directly or indirectly related to trauma and PTSD. And even the people who are supposedly dying from AIDS aren't really dying from AIDS. They're dying from non-adherence, almost always related to substance use, depression, hopelessness, and other trauma-related issues. So I think in our effort to get to zero, it is important that we just not focus on getting to 0 AIDS-related deaths, but at getting to 0 preventable deaths among people living with HIV. And doing this will require a focus on trauma. So we, in an effort to develop a model of trauma-informed primary care, we teamed up with the Positive Women's Network USA and convened a working group of 27 leading national policymakers, trauma experts and advocates from the government, military, academia, clinics, and community organizations to identify evidence-based building blocks of a practical model of trauma-informed primary care that addresses both intimate partner violence and lifelong abuse. And the model we developed, and I'm going to not go through it in detail, even though this is already somewhat oversimplified, has 4 core components and rests on a robust organizational foundation. It's vastly oversimplified, but for me as a clinic director, this was the guidance I was looking for when I first tried to transform our program. So the first element of the model is a trauma-informed environment that is calm, safe, and empowering for both patients and staff. The second is screening, or better said, education and inquiry. Providers routinely inquire about current violence, the consequences of lifetime abuse, including PTSD, depression, and substance use, and they consider whether to inquire about the details of past abuse in the course of their relationship with each individual patient. And finally, patients are directly linked to on-site and community-based interventions that promote safety and healing from current and lifelong abuse. I'd just like to be a little bit more specific about the responses because the graphic is so oversimplified in this regard. I think it's very important to know that there are many practical, evidence-based interventions that have proven efficacy that can be integrated into a busy primary care clinic that can help people become more safe in the face of intimate partner violence, cope better with the effects of lifetime abuse, and improve many of those social determinants of health that are on the care continuum and that are related to trauma. For the sake of time, I'm just going to say that the philosophy of healing from lifetime trauma involves improving damaged connections and that includes connections that have been damaged with other individuals, connections that are physiological connections that have been damaged in the developing brain and body, and improving connections with their own bodies. Oftentimes people have experienced trauma, are really at war with their own bodies, and are struggling in that regard. This next slide is really just for the conference record. There are a slew of interventions under each of these categories that are able to be integrated into primary care programs that have evidence of efficacy. We've done a number of pilot studies of these interventions, including one called Seeking Safety, which is a group therapy for complex PTSD and substance use. Lastly, I'm going to end. So in terms of trauma and PrEP, recent trauma, past trauma, and trauma-related conditions are known impediments to adherence. And this is going to be in HIV treatment as well as in PrEP. And you know, if we do a really good job and we recruit the right people, the most at-risk people into PrEP clinics, young Black gay men, transgender women of color, Black women in the Southeast, I think we have an ethical imperative to address trauma in addition to giving them PrEP, because these individuals most likely are not going to die from AIDS even if they get HIV. These individuals are facing immediate threats to their life from substance abuse, overdose, depression, suicide, and murder. So in conclusion, recent and past trauma are linked to poor outcomes at each stage of the HIV care continuum and are the principal causes of death among most people living with HIV. Evidence-based practical interventions exist to help people heal from and cope with trauma that can improve health outcomes on and off the care continuum. And trauma-informed primary care is a promising model for HIV prevention because it addresses the principal causes of medication non-adherence in both HIV positive and in PrEP patients. Thank you so much.
Now we will hear from Dr. Carol Camlin, who is an associate professor of obstetrics, gynecology, and reproductive sciences, and has another appointment, as well as that one, within the Center for AIDS Prevention Studies. And she will be talking about, among other things, her R01 grant, which is very exciting and has to do with the SEARCH trial. Thank you, Carol.
Thanks so much, Susan. Thanks, everyone, for your attention at the end of the afternoon here. I'm really grateful for this opportunity to share with you some insights from social science research that we're conducting as a part of the SEARCH trial. And for those of you who don't know, SEARCH is one of the 4 main global trials evaluating the test and treat strategy. And you can see some photos of the SEARCH trial activities, and on the bottom right is the qualitative team that has produced a lot of the research that I'm going to be sharing with you this afternoon. The team and babies. So essentially, SEARCH is asking this question: can ART shut down new infections with a test and treat strategy that has a streamlined care approach? And then what are the secondary gains or collaborative benefits of this strategy in terms of maternal and child health, TB, educational outcomes, household earning power? We're interested in learning what's the best way to do it and what it would cost. Also, SEARCH is asking, can efficient HIV chronic care models be adapted to establish care for other chronic diseases like hypertension and diabetes? So we're also interested in how to integrate HIV into and to normalize HIV by integrating it into delivery of other chronic health care services. So this is a really large trial in 32 communities in Kenya and Uganda involving over 334,000 people. So it's really a massive undertaking. And I'll just very briefly talk about the SEARCH intervention itself and then explain how social science fits within it. So it's probably easiest to think about the SEARCH intervention in terms of the UNAIDS 90 targets. The targets, not the cascade. Thank you, Judy. Not to review what they mean, but really for the first 90 in SEARCH, we used a hybrid testing model that included providing multi-disease services, screening, and HIV testing in community health campaigns in these communities, followed by home-based testing for those that didn't participate in the campaigns. For the second 90, we had the intervention of rapid linkage, appointment reminders, and improving provider access through either face-to-face meetings or telephone calls. And for those that didn't attend, follow-up clinic visits, intensive tracking of those individuals. And for the third 90, we used a streamlined care approach. And just to summarize very briefly, that essentially meant cutting down the intervals, longer intervals between clinic visits, and then cutting down the waiting time in clinics so that it's more easy for people to integrate care access. And then just a friendlier environment, a more patient-centered and friendlier environment in the clinic. So the standard of care in search has been whatever the countries were doing, and that has been allowed to change over time. And we have a number of different social science research studies embedded within the search trial, including a household socioeconomic survey that measures impacts on outcomes in communities in terms of livelihoods, schooling, things like subjective life expectancy and aspirations of various kinds. There's a social network study to look at how social network characteristics are influencing care cascade outcomes. And there's a longitudinal qualitative study, which is multifaceted, but the overarching aim is really to deepen our understanding of the social and behavioral and implementation mechanisms, whether they were expected and planned or unexpected, through which search would achieve its outcomes. So in other words, understanding why the intervention works, why it fails, if it does in some countries or settings, and how it works in diverse settings. And we use a variety of different kinds of methods for that, and in terms of our analyses, we're using explicitly constructivist grounded theoretical approaches, but we draw on social theory, behavioral theory, and even some humanistic perspectives. So, and then finally, there's an affiliated study, and I'm leading the longitudinal qualitative study as well as this affiliated study with a search trial that is looking at the impacts of population mobility on the effectiveness of search in achieving its outcomes, and mobility and its impacts on care cascade outcomes. So, what have we learned so far in search? Search was one of the first groups to achieve and exceed the UNAIDS 90-90-90 targets globally, and this was a major achievement that was recently published in JAMA and presented at the International AIDS Conference in Paris this past summer. So just using the approach that I just described, we were able to achieve and exceed the targets in just a few short years. And does this work? Have I figured out how to use it? In any case, I'll describe it. On the bars to the left, is the proportion of tested and know their status, and the bars in the middle are the proportion on ART among those diagnosed, and the third set of bars on the right is the proportion of those on ART who are virologically suppressed. And the colored bars represents where things were at baseline and then at follow-up years 1 and 2 after the intervention. And the next slide just shows you those cascade outcomes by gender. And if you just look to the far left, you can see compared to women, men had at baseline 62% aware of their status versus 74% among women. So that changed a lot. And social science has really been a pillar of search from the very beginning, and we've used social science research in search in real time to feed back findings to optimize the intervention as it was being implemented. So one of the first things that we learned was that there were a lot of structural and cultural barriers that hindered men's participation in the testing campaigns. So we were collecting data as these campaigns were rolling out and found that men's livelihoods and their mobility meant that they were often away from these rural homesteads that were the settings of these campaigns. They had problems accessing services, accessing the campaigns during work hours and in these locations. Also, there were cultural factors, masculinities that were prevalent, that were kind of counter to care-seeking behaviors of all kinds, and valorized risk-taking that men and women agreed made men disinterested in testing and likely to opt for testing by proxy. As in, I send my wife, she gets tested, and then I infer my own status from her status. We found that men really viewed the health campaigns just as they viewed clinics, as female spaces where they weren't comfortable being seen and joining in. So Search listened to men, talked to communities, thought about what was needed, asked people what was needed, and pretty rapidly adapted the intervention in response to the qualitative findings. So new strategies were adopted to mobilize men, adapting location and timing to meet the needs of men, giving workplace CHCs, community health campaigns that is, at beaches where the fishermen were coming in and out, sometimes at night, so that we call them moonlight CHCs. Home-based testing that were not necessarily in the rural home of origin, but maybe at an affiliated home where they spent time when they traveled. There were incentives, sports activities, and other features that were specifically targeting men to increase demand and based on what men said they wanted, like football matches and boat races. We had men's spaces and services, like a men's tent, where men would find out about things that they wanted to know about men's sexuality, and they also get access to other chronic conditions that affected men disproportionately and linkage to male circumcision services. So, that was one example of the way in which social science has been used within the Search trial. We've also just been looking at how has it impacted these communities. Here comes this massive intervention that's really different from everything else prior to universal test and treat. I mean, here you have a situation where everybody's getting tested whether they feel at risk or not. Every services are being availed and close to the homes of people whether they feel that they need them or not. When they're feeling healthy, how does it impact on these communities? So when Search arrived, there were a lot of new disclosure events. There were a lot of new diagnoses. And Search arrived in the context of a lot of HIV-related stigma of all of it, in all of its dimensions and forms. So people felt that stigma was high. Both men and women, whether HIV positive or negative, anticipated stigma. But we found that for those in HIV discordant relationships, women were more often than men likely to stay in those relationships, and HIV negative men were likely to leave them. When there were negative consequences, such as violence or dissolution of a partnership, women were disproportionately likely to suffer those consequences. And couples testing was really, really important, especially for women, providing a safe space for disclosure for women. So Search has precipitated new opportunities and anxieties related to disclosure of HIV positive status. And our tentative conclusions are that perhaps some of the norms, beliefs, and attitudes that are stigmatizing are changing. We're finding in the beginning of our longitudinal view that the benefits of ART among a bolus of new individuals is emboldening people living with HIV to openly engage in care in new ways. And people living with HIV are very actively engaged in the process of encouraging people to test, encouraging other people to enroll in care, stay adherent to medications, and so forth. I encourage you to read this forthcoming article it's coming out in the next month in the Journal of International AIDS Society about these findings. And so we're, with this paper, contributing to a scholarship on therapeutic citizenship in anthropology. Don't have time to talk about it, but essentially what we're finding is that people are telling us that it's more easy to talk about being engaged in care than it was in the past. People are openly talking about their status. I'll give you just a moment to read this slide. If so-and-so is disclosing her status to people, why not me? People are very free with their status. Hey, so today's my clinic day. Let me go for the drugs, they'll say to other people. There are a lot of narratives of people living with HIV encouraging others to test. This woman talking about her brother, he's grown stronger, he respects me, he appreciates much what I did for him. People living with HIV encouraging others to to go to appointments and offering to take them there themselves. Find out from the provider when is that appointment and make sure that they get there. I love this quote from this woman who says about another woman in her community, "I would love it if she lives longer and manages to take care of her children since she's a widow." People encouraging others to stay adherent. This woman who's talking about her neighbor, she was complaining that the ARVs were making her feel very sick and thinking of not taking them anymore. I was talking to her, trying to encourage her to continue adhering to drugs, telling her that the side effects won't last for long. Here's a narrative from someone who's talking about, this was not someone hired to be a treatment supporter or buddy. This is someone who's just volunteering to be that person for a friend of theirs. So our conclusions from this particular work really highlight the role of people living with HIV/AIDS in these sorts of interventions. What we're seeing is that the personal experiences of people living with HIV may make them less judgmental and more empathetic counselors of people who are emerging from denial and profound self-stigma. They are eliciting behavior change through social proof, as the marketers would call it, which is, for the psychologists among you, improving positive expectancies about the efficacy of ARVs, and vicarious efficacy. In other words, demonstrating for people, this person, socially similar to me, is succeeding at whatever the behavior is, testing, enrolling in care, taking ARVs. Therefore, I can do it too. And we've talked about what's driving it, and what we feel is driving it is this process of transformation of the spoiled identity, per Goffman's original conceptualization as stigma as a social process that results in a spoiled identity. They're taking that stigmatized identity, transforming it, fashioning a new valorized identity as an advocate for engagement in testing and care. So we would like to call on people, if you really take no other message away with you today, it's this. People living with HIV/AIDS, you know, nobody has asked them to do this. They're by and large not being paid to do this, unless they're a peer educator. They were not hypothesized to play a major role in making search work. Yet we have found that they are engaged in bringing about the social changes that are going to improve health of communities. And I'd like to call on all of us to think about ways in which we can allow people living with HIV/AIDS to take leadership and let them lead efforts rather than exerting new forms of control, like expecting everyone to disclose, expecting everyone to start ARVs right away, same day and so forth. Allow them, keep rights and justice in the forefront. But let's do this in order to envision new health systems and community partnerships in which people living with HIV/AIDS can take on new forms of leadership. Keeping in mind also this caution from Paulo Freire that the horizontal process of peers or equals talking among themselves and determining a course of action is key to peer education's influence on behavior change, key to the transformations that we need. I will conclude by pointing you to a correspondence that we published last year in AIDS called Strengthening Universal Test and Treat Approaches with Social Science Research. And just thanks to the participants in the research, the amazing team at Search that I am so honored to work with, and our funders, advisors, and collaborators. Thank you.
Wow, what an excellent panel. Great presentations, thank you. So I think this really demonstrates that when you hear thoughts about how the social, behavioral sciences, and economics are irrelevant to answering HIV issues now, you can see that that's quite untrue. If we're going to move things into practice, we need to be thinking about these other issues. So I'm going to take about 10 minutes, 5 minutes into your break to take questions. Sheri.
Hi, everyone. Ooh, I'm too short to talk up there. Thanks so much for this really amazing panel, such great talks. So one of the things that we were thinking about, the title of the panel is really about scaling, and I was wondering if any of you guys could really address whether the interventions you presented today, whether there's been any political discussions with policymakers, stakeholders, to move these things to the next level that is out of the sort of RCT and into the hands of public health departments, and well, I guess Al's at a public health department, but in places, you know, where you're working, Sheri and Sandy, for example, how you move these things forward into bigger groups. So that's for everyone.
What? So I'm happy to start. So I think that all the interventions are sort of at a different phase of scaling up. So the food support, I think there has been a tremendous amount of advocacy by non-governmental organizations, realizing that this really needs to be integrated into medical care. So really by their lead, we had the opportunity to present at a Senate and congressional hearings in DC to move that discourse forward. You know, and as I mentioned, I think that, you know, that Governor Brown in California has, you know, taken on the cause, at least by doing a statewide demonstration project, to look at the impacts of, you know, whether provision of food really will reduce hospitalizations and ED visits, which is their primary interest as a starting point, so that it really will be cost effective in addition to health promoting. So I think from food support, that is definitely happening. And even in the Getting to Zero campaign, I think a lot of the advocacy groups have helped convince the Getting to Zero campaign. Many of you are here in San Francisco, that food support needs to be part of that, and that is indeed part of the Getting to Zero campaign. So I think that is definitely moving along. And I think internationally, the World Food Program has certainly helped push and promote implementation of food support early in the process of people starting ARVs when they're most vulnerable and most sick as a short period of time, and they are transitioning them into livelihood interventions. The interesting thing about the world of the livelihood interventions and, you know, some of these financial programs, some of the you know, microcredit programs and other things that Sandy discussed, is that there's a lot of them actually being implemented and going on, but there really isn't a lot of data behind them. So in some ways, the implementation, everyone recognizes we need to do this, the implementation is just happening, and now we're sort of catching up to try to evaluate it.
I have just a quick answer to that, this highlighting trauma. There was a presidential White House working group on the intersection of violence against women, gender-related health disparities, and HIV that produced a report, and the latest national HIV strategy now includes a call to address trauma and PTSD in the care of women, inclusive of transgender women living with HIV. SAMHSA is taking a major national leadership role in this, and there's a group of 41 of us participating in the creation of federal guidance, and so there is about to be released federal guidance about the core components of an evidence-based model of trauma-informed primary care, and that's going to include a toolkit that will be released by the beginning of next year for any clinic to begin adopting that process. And the grants that they will give will encourage, if not require, a response to how that clinic is doing substance use and mental illness inclusive of a trauma-informed approach. And that type of policy initiative can be very effective because of the funder having so much power.
Sandy?
So thank you for that great question. So to build on the economic interventions and what Sheri just covered in terms of the food and livelihood activities, I think the other economic intervention that's the closest to scale would be conditional and unconditional cash transfers. But of course, these are being implemented at scale in more than 90 countries globally because they're being used for anti-poverty and social protection strategies. And so there's an interesting sort of parallel line of scholarship that's happening right now, looking at the spillover effects of these government-run cash transfer programs on HIV-related behaviors in retention and care. And I think Harsha Thiramurthy at UNC is leading a lot of this work, and they find when there are data available that often these government-run cash transfer programs are having these beneficial spillover effects on HIV-related outcomes. But the studies of conditional and unconditional cash transfers specifically designed for HIV-affected households and patients are sort of in development, like the one we presented. So we've just been funded to do a larger cluster randomized study of the cash transfer strategy for treatment adherence, and we have members of both the Ministry of Health and the Ministry of Finance in Tanzania as part of the investigation team. And our goal there from a political standpoint is to have the ministry that would eventually fund such an intervention be part of the study team.
Let me go on to get another question. Dr. Gail Wyatt.
Thank you. I've been trying to get to this microphone all day, so it's good to be here. I've really enjoyed your presentations, and I want to pose some issues that I think are in the room and probably elephants, to say the least. And that has to do with really looking at the cultural components that I think I've not heard a lot about, if anything, regarding women, and African American women at that. And because of that oversight, that I don't think has been really addressed. Oh, I've heard a lot about trauma. Thank you, Eddie, for your really hard work. I know it's not easy. I started in 1980, didn't really hear a lot about my work, but I did hear what is going on right now. It's really important that we don't overlook African American women. For those women who've had the courage, like Gina and myself, we've been at the forefront the entire time of HIV. And depending on what cities we go to, we sometimes don't hear any mention at all of color, of class, of culture, of gender differences when it comes to HIV. I don't think that you can make generalizations, and I think that because of those concerns, we're having a conference of our own next week on the paradigm shift, the need to pay attention to African American women in the cultural context. And why is that important? Because women are not men. We made the point, or heard the point, that there is a difference. But we really need to understand that you cannot study trauma without studying post-traumatic slavery syndrome. All of these cultures and all of these countries are looked at only through the prism of HIV. That's a very narrow perspective when you're not looking at the history of the country and who's been denied services, who is more socialized not to go because of the inability of really having these services available. Looking at data in San Francisco that's a model maybe for white men, but that shouldn't be a model for the rest of the United States. So I think we have to be more cautionary about the statements we're making and really where we are. We can't exclude one whole gender and then wonder why the tables, the graphs are spiking and just say it's because they don't come to the table. They don't have a table to come to. There aren't any services for women at risk who are of color. They're not in any language other than English. We need to be serious about the limitations so that we know where we need to go. All of the answers are not given by what's been presented. I think we have more questions to ask than perhaps are answered. And I think that if you want to understand how to study African American women, at least live stream the material next week. Because if you don't take the time to understand there is culture, and you can't just overlook it and jump over it as if it doesn't exist, even internationally. It's almost like people in South Africa don't have any group cohesion and they just went through apartheid, and they fought apartheid, they have no community glue. It doesn't seem to fit the reality of the people when the interventions are very Western. So I encourage you, I challenge you to take the time to listen to another perspective on African American women, by African American women, many of whom are not represented in this room, perhaps from different disciplines, because the answer just isn't in HIV. It's having a comprehensive understanding of the economic and social and structural, educational, relationship issues that have been a burden for one group of people for hundreds of years. And unless we look at the issue of why are these women so much at risk, who are they having sex with if you never look at them? How is it that those rates are so high and no one's really concerned enough to call attention to it? Well, we are. And I think it's time, and we ask for your support by coming out, listening, and starting the conversation. Because African American women should be at the table, should be at this conference, and should be leading the research on African American women. I wouldn't dare do a research project without a man having sex with men if that's what I was studying. But we have had people in this room who've conducted research on African American women with not an African American colleague, not a research assistant, present. And I think it's time that we look at the ethical and the moral issues along with the content and what's already known about these populations if we're really going to make progress. So thank you for your contributions and your hard work, but I still think we have a long way to go, and particularly when it comes to acknowledging the work that has been done, and sometimes all alone by those who've done it.
Thank you, Gail. I knew you would have an important thing to say, so thank you very much. All day. Yes. And then I'm afraid only one more question.
Hi there, guys. I just, Conal O'Cleary from the Harvard CFAR. I bring fraternal greetings from our Behavioral and Social Sciences Core. Thank you for such an amazing panel, you guys. I have questions for each of you individually, but Ed, I was really impressed by the data that you shared and horrified too by the fact that it's psychosocial factors that are more lethal to some of your patients than the actual consequences of HIV infection. The thing I wanted to comment on was actually the title of this afternoon's panel, what's being implemented and scaled. And wouldn't it be lovely if they were the same thing? But I think we have to get real around the kind of dose that is required to address trauma-related disabilities and post-traumatic stress disorder in people living with HIV, regardless of which group we're talking about. That empirically supported treatments for post-traumatic stress disorder range from about 10 hours of treatment to about 20 hours of treatment. And Gail, I know you're familiar with Sanisha Dale's work addressing trauma in HIV-infected African-American women. And the dose of her intervention with good initial evidence for efficacy is also 12 sessions. And these, by definition, perhaps aren't scalable. They certainly aren't scalable in some of the international settings we've been hearing about. But even in primary care settings here in the US, we have to get real around what can we legitimately do in primary care. And maybe what we're looking at for providing fully effective and patient-centered care for folks with HIV in primary care settings is establishing better links and better connections to behavioral health services and making sure we've got good assessment and referral built into to primary care. And our group recently published some data saying that we're really crap at doing that. We're recognizing depression about half the time, not surprising. Patients are dying of suicide. We're recognizing PTSD less than 20% of the time, substance abuse less than 10%. So we've really got a lot of work to do if we want to continue to face forward and address some of the psychosocial challenges associated with stigma and with PTSD. Thanks, guys.
Can I just quickly respond to that? First, Gail, thank you for your comments. I'm a newbie. I've been working on this 7 years. You and others have been working on this issue for decades. I'm extremely humbled to be a white, gay man working primarily with African American women and other women of color. And I do recognize your work, and I wish I had more than 15 minutes to describe both how humbled I am by working with this population, how freaked out I am by the trauma experienced by this population, how deeply affected I am, how much I don't know, and how much I seek to know. And so I really appreciate your advocacy and comments. In terms of the last comment, I'd just like to say we have a $3 trillion health system in this country. We already have many initiatives designed to address the opioid epidemic, to address suicide, to address high-cost, high-need patients. And I think if we can understand that most of these conditions are trauma-related, and if we can have a lattice, an effective lattice that unifies what is a very, very fragmented approach to addressing these disparate problems, we will have a more effective response, a more cost-effective response, and we will be able to raise the bar of what we consider to be effective care in clinics, and especially in Ryan White clinics. If we can't do it in Ryan White clinics, if we can't interrupt some of these impacts of trauma on women, young Black gay men, Black women in the Southeast, who, the most vulnerable populations to HIV, where are we going to be able to do it? And I think we can.
Okay, wonderful presentations, wonderful questions and comments. Thank you so much, everybody.